This conference will now be recorded.
Down syndrome screening. As you know, 95% cases are due to trisomy 1, 4% are due to translocation, which will involve chromosome 21. 1% they will show missing. Extra chromosome 21 is of maternal origin in 90% of cases, and mostly this is due to the non-disjunction in the first meiotic division. Incidence is 1 in 700 live births, commonest chromosomal aneuploidy, and compatible with long-term survival with implications for the individual, parents, and society. But if the cutoff is 1 in 150, then it means like you have to calculate the score in the first trimester screening and then the second trimester screening. And if it is found to be 1 in 150, this is the cutoff. Then you need to send this woman to the center for karyotyping for further analysis, because the screening is just for screening, that if someone is at a high risk, and then for the confirmation of diagnosis you need to carry out chorionic villus sampling testing or amniocentesis. You know about the timings, that when you should do this CVS, you should do between 11 to 13 plus 6 weeks of gestation, and amniocentesis should be done after 15 weeks of pregnancy. So 55% of the neonates with the Down syndrome, they will have structural abnormalities, as we discussed before: cardiac abnormalities, active ventricular septal defects, urinary ectasia, urinary tract problems, limb defect, and genital cath. But the main problem is that they are going to have severe learning disability. They will have brachycephaly, upstanding palpebral fissure, brush feet spots, apicanthal folds. They can have open mouth with protruding tongue, increased risk of leukemia, thyroid disease, Alzheimer's, and 10% chance of epilepsy, and lifespan is going to be normal. Different tests can be done to screen Down syndrome. Integrated test. Here we will take the nickel toxicity and pregnancy associated plasma protein at 10 completed weeks of gestation, and then we can take alpha fetoprotein, P beta SEG, serum estriol, and inhibin A at, and this integrated test is done at 40 to 20 weeks of gestation, like if the patient has presented late in the pregnancy. Okay. And this is most effective screening test with a false positive rate of 1.2% and 85% detection rate. This is integrated test. Then serum integrated test. It means that we will integrate, we will do the all of this integrated test, but we will not offer nickel translucency, because it is the second most effective test, and it has a false positive rate of 2.7% and detection rate of 85%. In combined test, what we take this nickel translucency, P beta SAG, pregnancy associated plasma protein, PAP-A, at 10 completed weeks of gestation. But the false positive rate is very high, 6.1%, detection rate of 85%, so it is not done now because very high false positive rate. This is only if they ask in the exam that which test is a test contains how many components. It is only to answer such questions. In cardiovascular test, we have to test alpha fetoprotein, serum estriol, P beta SCG, and inhibin A at 14 to 20 weeks gestation. False positive rate of 6.2% and detection rate of 85%. In triple test, we can test alpha fetoprotein, serum estriol, P beta SCG at 14 to 20 weeks gestation, and 9.3% false positive rate, unacceptable. WHO says that the false positive rate should not be more than 5%. So the detection rate is 85%. Then we can do a double test, like we can test serum alpha fetoprotein and P beta SCG at 14 to 20 weeks of gestation. False positive rate 13.1%, detection rate 85%, so very high false positive rate, so not acceptable. Nickel translucency is carried out at 11 to 13 completed weeks of gestation, and false positive rate 20%. So that's why none of these tests is done in isolation. One test is not going to be so suitable. So from an 85% detection rate, the cost in the UK per Down syndrome fetus, it will means that it is costing like 15,000 to 17,000 British pounds, which is very high. So it has to be judicial that how you are going to use. So integrated test, it means that diagnostic procedures and then the pregnancy related loss rates, you have to explain it to the patient like that. So in the integrated test, the fetal loss rate can be 9 in out of 100,000 in addition to the background fetal loss rate. NICE guidance, it has given good recommendations that all pregnant women, they should be offered screening for Down syndrome. They should understand that this is only their choice if they want to have Down syndrome screening. So screening should be performed by the end of the first trimester, which means at 13 weeks and 6 days. But if somebody wants to have it earlier or she wants to come later, then it should not be refused, because I will tell you that now we have more methods to detect it. The combined test, where we take nuchal translucency, beta HCG, pregnancy associated plasma protein A, it should be offered to screen for the Down syndrome between 11 weeks and 0 days and 13 weeks and 6 days. For women who book later in pregnancy, the most clinically and the cost-effective serum screening test is triple or quadruple test, and it can be offered between 15 weeks and 20 weeks of pregnancy. When it is not possible to measure the nuchal translucency, like maybe the mother is obese, BMI is very high, so we cannot see clearly through the anterior abdominal wall, then we should offer serum screening like triple or quadruple test between 15 weeks and 20 weeks of gestation. So you should give all information to the woman on the first contact when she is coming to you, and then you have to see that how much is her risk. And then you should tell that what will happen, because you cannot just screen and leave her nowhere. You have to tell her that what is this procedure, what does it involve, and what will happen after that. So if the risk is found to be higher, she will be shifted to another center where they will carry out certain tests. Then you should tell them that the screening test, it is not going to tell us about everything. It is not diagnostic. It is just telling us that she is at a higher risk. So we will have to do more definitive tests like CVS and amniocentesis. Then we need to tell them that what is this procedure, what are the risk factors, what is the fetal loss rate. Then we have to give them balanced information about the Down syndrome, because everyone will not go for the miscarriage. So, and then appropriate counseling should be offered. And though the test is positive, still you will offer routine anomaly scan, which is offered at 18 to 20 weeks, but you will not offer it routinely to screen for Down syndrome using the soft markers. So the presence of soft markers, with exception of increased nickel fold on the routine anomaly scan, it should not be used to adjust the risk of the Down syndrome. The presence of increased nuchal fold, which is 6 millimeter or more than 6 millimeter. Okay, this is 6 millimeter, or 2 or more soft markers on the routine anomaly scan, they should want the offer of a referral to a fetal medicine specialist or an appropriate healthcare professional and who has special interest in the fetal medicine. Just don't forget this number. In the many MCQ books which are old, the number is written 2 to 3 millimeter, more than 3 millimeters. No, even up to 5 millimeter doesn't mean that there is any risk. So the test is positive, then you will send them for further assessment. Actually, the way of screening is that you will do the first trimester screening, which we have said that in the form of nuchal translucency, PEP, and HCG. You will calculate the score and keep that. This score will not be shown to anyone. Now an independent score assessment will be done in the second trimester. So then the second trimester's results, they are seen. You can offer integrated test, you can offer that serum integrated test, depends that on which stage of pregnancy the patient has come to you. So then you will calculate her risk based on the second trimester screening. Then final result, it is given by combining the results of first trimester screening and the second trimester screening. So when you will combine both of them, then you will give the cumulative risk of this woman And if it is more 1 in 150, then it means that she is at a higher risk, so you will have to refer her for further testing. Okay, let's say now the screening test is positive in the second trimester, so what should be done? Your first step is to ensure that the date of the duration of the pregnancy is correct. You can calculate from the LMP, but if you have any doubts, you will have to do dating scan. If the dates are inaccurate, then you will have to do the retesting, and you will have to do the retesting at the appropriate time, and then you will calculate the risk. Similarly, sometimes in the exam they will give you a person whose date of birth is written in a wrong way, that her date is another year and they have mentioned another year on the report. Then they will ask you that what should be done. So they will give you options like that. Because of her age, she's at a high risk, so she should go for screening. You will not calculate like this. You will have to start the screening again. And let's say that if she is at some later stage in pregnancy, then your task is double. You will have to find the most suitable test, and then you will have to, depending upon the duration of pregnancy, and then you will have to calculate the risk again. Don't fall into this trap. Don't give any estimation. No, you will have to repeat the screening again, and you will have to counsel her according to the risks. So you have found everything that this thing is abnormal, then you will have to give them appropriate counseling, and you will tell them about different options, like they have the option of continuing the pregnancy, or they can go for termination of pregnancy if their faith allows it, and they have no contraindications for termination of pregnancy. Then you will calculate the risk, and then you should remember a few other things, like if mother is carrier of translocation between chromosome 14 and 21, then 15% chance of recurrence. This is not for the primary baby. This is for the recurrence. That second baby will also have the same problem. If translocation is of paternal origin, then and the translocation is between chromosome 14 and 21, then 1% risk of recurrence. If mother or father, they have trisomy translocation 21-21, then the risk of recurrence is going to be 100%, because it is coming from mother or father. The baby is going to be with Down syndrome in any case. That is the point. Okay? Then you don't have to just talk about the traditional screening. This article was published in the Obstetrician and Gynecologist in Jan 2019. I have told you people before that you have to do many topics from the obstetrician and the gynecologist. Okay? So Down syndrome screening we have been doing for the last 40 years, but things are changing. Okay, so as we know that as the age of the woman increases, the chance of having Down syndrome also increases. So the risk increases in the pregnant women who are 35 years old or older. So then for the screening, you can use the first trimester screening and the second trimester screening. I will just show you that what are the new incidences, that how much helpful is one test as compared to the other test. So we can see here. Neckle translucency, it can be done at 11 to 13 weeks of gestation, okay? And this is helpful. And then in addition to that, what are we going to do? We are going to test the beta HCG and CAP. So these two things we are going to do, and false positive rate of 5% and 90% detection rate. Then screening in the twin pregnancies, it has always been an issue. The incidence of twin pregnancies has increased from 1990 onwards, mainly due to assisted reproductive technology. Okay. So the increase mostly is in the dizygotic twin pregnancies. The detection rate of trisomy 21 for the first trimester combined test in twin pregnancies is similar to that in the singleton pregnancies. However, in monochorionic twin pregnancies, the false positive rate is twice as high as in the singleton pregnancies, because an increase in the nuchal translucency and in one fetus. It could be either because of the early manifestation of the twin-to-twin transfusion syndrome also. That's why we cannot use it reliably. And in the dichorionic twins, an individual risk is given for each fetus, but in monochorionic twins, the risk is calculated for each fetus. and the average of the two is given for the whole pregnancy. You are measuring the risk for one baby, then measuring for the second baby, and then you are giving the combined risk. Additional ultrasound markers. Here the point is that these methods are very effective. Like they have a false positive rate of less than 3%. But the problem is we don't have any highly trained staff who can identify these problems, these soft markers. So that's why the NICE says that you cannot use soft markers for screening or for confirmation of a diagnosis. But for the sake of exam, you should know what are the soft markers of Down syndrome. Absence of nasal bone, increased resistance to the flow in the ductus venosus, and tricuspid regurgitation. Okay, these are the signs. Then, in addition to the Down syndrome, we should be concerned about the screening for the trisomies 18 and 13 also. Cell-free fetal DNA is very helpful because its false positive rate is very low and it can detect very reliably, and then it is a non-invasive test. So the risk of miscarriage for the pregnancy will not increase. So how we can do that? We can take the maternal blood and we can screen for the cell-free DNA. What happens? Cell death, it results in the release of DNA fragments from the nucleus to the plasma, and in the 1990, increased quantities of these fragments they were identified in the plasma of the patients with malignancies. So then it was used for the diagnosis in the pregnancies also. So cell-free DNA in maternal plasma, this is a mixture of DNA fragments arising from the dying cells in the mother and the placenta. So placenta is the source of the cells. Okay? So the proportion of the fetal to the total cell-free DNA. This is the proportion, that how many cells from the mother, how many from the baby. This is referred to as the fetal fraction, and it is usually about 10%. In pregnancies with fetal trisomies, the number of the fragments derived from the extrafetal chromosome as a proportion of all sequence molecules, it will be higher than in the diploid pregnancies. The fetal fraction is vital to our ability to detect a small increase in the amount of a given chromosome in the maternal plasma in a trisomic pregnancy compared with a disomic pregnancy. For example, when the fetal fraction is 20%, it means that if there were 100 units of maternal cell-free DNA fragments of chromosome 21, then there would be 20 units of the chromosome 21 from the fetus and 80 units from the mother. So it means fetal fraction is 20%. However, if the fetus is not normal when it comes to chromosome number, and the mother is carrying a trisomic pregnancy, then there would be 30 units from the fetus and 80 units from the mother. Therefore, there would be a total of 110 units of chromosome 21 compared with 100 units of all the other chromosomes. So that's why the additional copies of the chromosome 21, you will know that it is coming from the baby. DNA testing requires that the fetal fraction at a minimum should be 4%. If it is less than 4%, then fetal DNA cannot be detected. So in cases of aneuploidies, the detection rate, it was like 99.2%, and the false positive rate, it was less than 1%. I will just show you how. This table is very important. So here is comparison of the different methods of screening for the fetal trisomy. Different methods are used. If maternal age is used, then the detection rate is only 30% and false positive rate is 5%. If we use double test in which we use alpha fetoprotein and free beta ICG, then the detection rate is 60 to 65% and the false positive rate is 5%. For triple test, alpha fetoprotein, free beta ICG, serum estriol, the detection rate is 60 to 75% with a false positive rate of 5%. For quadruple test, like here we are testing alpha fetoprotein, free beta ICG, serum estriol, and inhibin. The detection rate is 70 to 75% and false positive rate is just 5%. In first trimester, if we do combined test, detection rate is 90% and false positive rate is 5%. Now, if we take cell-free fetal DNA test, then detection rate is 99% and the false positive rate is going to be less than 0.1%. So you can see that cell-free fetal DNA, it has the lowest false positive risk. So this test is more reliable. In 1 to 5% of the singleton pregnancies, no result is given from the cell-free DNA test after first sampling, mainly because of the low fetal fraction. On repeat sampling, a result is obtained in around 60% of cases. The main determinants of low fetal fraction are maternal obesity and small placental mass. In Edward and the Fetal syndrome, the placenta is small and poorly functioning, which is evidenced by the low beta HCG and PAP-A levels in the maternal diet, and this also explains the low fetal fraction and high failure rate in a failed cell-free DNA. So it means that increased risk of aneuploidies. So now you have taken the first sample and now which was not very helpful. Then those with a failed second, you will do the second sample. If it is positive, you will send the patient for more definitive testing. But let's say the second test has also failed, then you will have to carry out a detailed ultrasound scan assessing for the features of Edward and the Tau syndrome. So in the conditions that can be screened with the cell-free DNA, trisomy 21, trisomy 18, and 13. So we can screen them achieved for Down syndrome, for Edward syndrome, and for Tau syndrome. With cell-free fetal DNA testing, it is also possible to screen for fetal sex chromosome aneuploidies and some microdeletions such as V-George syndrome. However, it may not be appropriate to offer pregnant women screening for these abnormalities just because it is easy to do. So when we have to screen for microdeletions, like I told you in cases of Trisomy syndrome, then or a certain other problems, then it may not be possible to perform cell-free fetal DNA because it will not have a high detection rate. So if the sex chromosome aneuploidies, they are typically very mild and without any physical and intellectual disability. So the rationale for screening for the sex chromosome aneuploidy is not strong. With a relatively low detection rate of 90% or a high false positive rate of 0.4% and high failure rate. In addition, sex chromosome aneuploidy, it has a high rate of fetal mosaicism of up to 50%. Moreover, the test may reveal maternal aneuploidies such as 47XXX, where 90% of women, they would be unaware of this change because they will be living normally. However, the lethal form of Turner syndrome 45X0, which is associated with a very high nuclear translucency in the first trimester, and cystic hygroma or hydrops in the second trimester, they need to be investigated with an invasive test, not only for karyotype, but also to include subchromosomal analysis with microarray rather than the cell-free DNA. So for sex chromosome abnormalities, it is better to carry out microarray. In cases of twin pregnancy, we know that the incidence prevalence of twin pregnancies is approximately 3% of the live births, and with dizygotic twins, since they are more common than monozygotic, a ratio of approximately 70-30, excluding those pregnancies conceived by ART. Cell-free DNA testing in twin pregnancies is slightly more challenging since there are two fetuses that could either be genetically identical in monozygotic twins or genetically different in dizygotic twins. Ultrasound assessment, it can identify chorionicity but no zygosity. Therefore, like chorionic twins in ultrasound, they can either be dizygotic or monozygotic. Whereas monochorionic twins, they are always monozygotic. So in a monochorionic pregnancy, like monozygotic or identical twins, both fetuses, they will release the same amount of genetic DNA into the maternal circulation, and therefore this would not affect the cell-free DNA analysis for the aneuploidy risk. Majority of the dichorionic twins on ultrasound, they are non-identical. And these fetuses, they will contribute a discordant amount of cell-free DNA into maternal blood. So studies have shown that when they were using ultra-deep sequencing, then they saw that the discordance rate between the two children, it can vary by 2 folds. Therefore, if one of the twins is having aneuploidy and possibly it is contributing to fetal fraction below 4% for the satisfactory DNA testing, and the other fetus who has normal number of chromosomes, he is contributing higher fetal fraction, then this could lead to an error in the cell-free DNA result. This is because the contribution of the euploid, or the one having normal chromosomes, it will dilute the contribution of the trisomic fetus. So in the total fetal fraction. So you are going to get higher number of the normal copies of the DNA of the chromosome 21 and less copies of the trisomal DNA. Therefore, uh, the, it was proposed that the fetal fraction used to give a successful cell-free DNA result in dichorionic twin pregnancies, it should be the lower fetal fraction of the two fetuses and not the total fetal fraction. So it means that an increase in failure rate by threefold compared with singleton pregnancies. Therefore, cell-free DNA testing, it can be safely offered in monochorionic twin pregnancies with expected performance of screening as high as in the singleton pregnancies. And the cell can also be offered in the dichorionic pregnancy, but parents should be warned that the data on accuracy are inadequate. And if you are looking for the trisomies, then you should know that you will calculate the lower fraction of the uh, trisomic genes, because it may be because the copies are less, so you have to detect the abnormal gene. So if the cell-free fetal DNA results provides a high-risk assessment for trisomies, then you will have to give the option of chorionic villus sampling at 13 weeks. It is still visible for all, and versus opting for the amniocentesis at a later gestation. On the other hand, if the cell-free DNA results it provides at very low risk of trisomies, then the parents, they can be reassured that it is very unlikely that the baby is affected. So if we look at the different tests, then you should know that what is the detection rate, what is the false positive rate if you will take many samples. So you don't have to remember this, just remember that in cases of the trisomy, you are going to get the highest detection rate. That is the point. So if you have detected something, then what should be done? Combined screening at 11 to 13 weeks, what you will calculate: age, fetal nuclear translucency, and serum beta HCG. So you will divide them on the basis of the risk into 3 groups. High risk group, where the risk is more than 1 in 10. So you will refer this one for invasive testing. Now you have calculated it by the combined screening and you have found that the risk is intermediate. Then you should send these patients who have intermediate risk, they should go for self-fetal DNA test. If it is positive, like the trisomy has been detected, then you should send that patient for invasive testing. If the cell-free DNA test is done, it is negative, then you don't have to do anything. If you did combined test at 11 to 13 weeks and the risk is found to be very low, then you don't have to offer anything else. Okay? That's all you need to remember. So if we talk about the trisomies, then the highest detection rate if your baby is carrying trisomy 21. And cell-free fetal DNA, when you can offer it, you can offer it even after 9 completed weeks of pregnancy, but so that's why you can make the decision early. That is the point. So now another important topic from the talk: prenatal diagnosis in the modern era. So large prospective studies, they have demonstrated an improvement in detection rate for trisomy 21 from 7% from nuclear translucency alone, and it is like 99% if there is cell-free DNA. Small positive rate of nuclear translucency is 4.7%. Combined first trimester test it uses the measurement of the nuclear translucency and placental protein marker and like free beta ICG and pregnancy associated plasma protein A. The detection rate is 80 to 90%. In combined first trimester test, the false positive rate of approximately 5%. Then the health technology assessment of the antenatal screening for the Down syndrome, it has published in 2003 that integrated test using first and the second trimester measurement. This is the overall best test in the detection. Integrated test, it has false positive rate of 1.2% or detection rate of 85%. However, to allow women the choice of a first trimester test, it is recommended that the combined test should be offered. Regarding the role of integrated first trimester assessment, it is based on the Nicolai Days inverted model. This is the model, okay, you can see. So this is a model. What is the role? It is based on Nicolaides inverted model. This is the old model. Like you will start detection at 16 weeks, then what you will see at 24, 28 weeks, and then you will proceed. What we do here is that we will add screening test for the NCD here. This is the new model. Okay. So you will see sent to the specialist care. You have offered the test at 12 weeks. Then at 20 weeks, you can carry out the ultrasound to see that how this assessment is taking place, and then the specialist care, it can be referred between 12 to 24 weeks, and then at 37 weeks, you can see that how the baby was doing, and then at 40 weeks. Okay. So this is the inverted model. So in this model considers maternal characteristics and the obstetric history with ultrasound and biochemical testing of maternal blood to stratify women into the low or the high risk. Majority of the pregnancies, they follow reduced schedule of antenatal care comprising of the first trimester assessment at 12 weeks, a mid-trimester scan at 20 weeks, and then the maternal and the fetal well-being test at 37 and the 40 weeks of gestation. High specialized care between 12 and 24 weeks of gestation to try to predict and manage potential complications. Risk of complications such as miscarriage, preterm delivery, preeclampsia, and the fetal growth restriction, they can also be ascertained. All patients, they should be offered aneuploidy screening with maternal serum, free beta ICG, and PAP A at 9 to 10 weeks, followed by fetal nuclear translucency at 12 weeks. No PAP A, it is associated with increased risk of miscarriage and stillbirth. And this would enable classification of pregnancy into high, intermediate, or low risk. Those at intermediate risk, in the risk, they are reclassified as high or low risk after a second ultrasound scan that includes assessment of the nasal bone, blood flow in the hepatic artery, ductus venosus, and across the tricuspid valve. Those with high risk of preterm birth, they would also have first trimester measurement of the cervical vein. To predict preeclampsia and fetal growth restriction, a uterine artery Doppler and the mean arterial blood pressure, it would also be used. Measurement of sex hormone binding globulin and adiponectin levels, as they are associated with the risk of gestational diabetes in the patients. If an anomaly is detected, appropriate follow-up in terms of further imaging, it should be done. Means that ultrasound with or without MRI can be done, or fetal karyotyping can be considered as appropriate for your patient. Ultrasound scanning can only provide screening for chromosomal anomalies, so it is not going to confirm the diagnosis. So we will have to offer invasive testing in the form of chorionic villus testing between 11 and 14 weeks of gestation. Then amniocentesis can be offered at 15 weeks from 15 weeks of gestation, and they are only way to examine fetal cells and ultimately the chromosome component of the fetus. Karyotyping with the number and the microscopic appearance of the chromosomes, it can be asserted. It was traditionally used for the assessment of the babies. Testing has subsequently developed into both more targeted analysis such as FISH and more detailed analysis through the use of chromosomal microarray, which is also known as array comparative genomic hybridization. So we can write it ACH, but they are the same thing. So this molecular cytogenetic technology, it has an advantage over karyotyping that it can obtain a greater level of for detailed regarding chromosomal aberration. Highest resolution for conventional karyotyping by Gibbs bending, this is a 3 MB, but for the fish it is like 1 to 2 MB. 1 kb, these are the segments of the this chromosome DNA like this, that how much is required. So 1 kb kilobyte for a CGH segment. CGH, this is good at identifying aneuploidy and unbalanced chromosome arrangements. What is the disadvantage? It doesn't identify truly balanced translocations, low-level mosaicism, and triploidy. CMA, the problem with this type of microarray, this chromosomal microarray, the problem can be overcome by analyzing much smaller DNA changes that can affect only one nucleotide base. So this is known as single nucleotide polymorphism, or SNP. These are also called SNP based CMA. Chromosomal microarray, it can find copy number variants, which are alterations to large regions of the DNA of a genome, of which the significance is not known, but these are termed variations of unknown significance. CMA, it can facilitate the diagnosis of clinically relevant deletions or duplications in 3 to 6% of fetuses with an apparently normal karyotype, particularly those with a structural abnormality. Then what are NGS? NGS, these are next generation sequencing. The use of next generation sequencing, this is a group of high throughput DNA analysis sequencing technologies. It has enabled the interrogation of the genome to the gene level. In this setting, the exome sequencing, which is focused evaluation of the coding region of the genome, it is often favored, as this is 1 to 2% of the genome, is where 85% of the gene anomalies they will reside. 85% of the anomalies, they will lie only in this small region in the exome, so we can identify them. Invasive testing for fetal anomaly using exome sequencing DNA trios, that is an affected fetus. So proband, we have to match it with both parents. This technique has the ability to provide additional diagnostic genomic information in up to 10% of the cases, which is supplementary to that of the existing microarray testing. It is being evaluated by certain trusts, and then still the reports are awaited. NIPT, or non-invasive prenatal testing. Here we isolate cell-free DNA from the maternal circulation. Then cell-free fetal DNA, it is present from as early as 6 to 7 weeks of gestation, and in early pregnancy, it constitutes approximately 3.4% of the total plasma DNA. It will rise to 6.2% in the late pregnancy. Fetal messenger RNA is also present in the maternal circulation at an early stage. It is accepted that the placenta is the predominant source of the fetal nucleic acid. NIPT, it has therefore focused on diagnosis of paternally inherited traits for which the mother and the fetus, they were discordant, like including Rh status and the fetal gender determination. NIPT, or non-invasive prenatal testing, the fetal and Rh status determination has dramatically altered the management of the pregnancies in whom the women who are Rh negative, they required NTD. Comprehensive polymerase chain reaction, RHD genotype testing, it has been developed and then led to the introduction of routine NIPT for fetal Rh status for all Rh negative women. Non-invasive detection of a fetal gender. It also employs PCR for the detection of DNA sequences from the Y chromosome in maternal plasma. It has high sensitivity, 95.4%, and specificity of 98.6%. If performed at 7 weeks, it maintains sensitivity and specificity of 95%. It detects pregnancies at risk of X-linked conditions such as hemophilia and can avoid the need for invasive testing. In congenital adrenal hyperplasia, where the side effects of the maternal administration of the steroids to prevent sterilization of the female fetus, they can be avoided when the fetus is confirmed to be a male, because sterilization it will occur in the female fetus. So if you already know that this is a male fetus, so this side effect and this administration of steroids can be avoided. Similarly, immediate neonatal management in cases where ultrasound has suggested ambiguous genitalia, it can be improved by NIPT of fetal gender. Its use for fetal sex selection and therefore the issue of the ethical basis for offering this test for anything other than medical indications. Rapid Another technique, it has shown the ability to detect or exclude paternal inherited de novo mutations for autosomal dominant conditions such as skeletal dysplasia, like Thorne-Cropper dysplasia, achondroplasia, Apert, and Crouzon syndromes. Also, Gaussian dystonia, Huntington's disease, and myotonic dystrophy. And rapid has also shown the ability to detect autosomal recessive conditions where the parents they carry different mutations like cystic fibrosis, beta thalassemia, and congenital adrenal hyperplasia. The translation of non-invasive prenatal diagnosis for single gene disorders into a clinical setting. This is an ongoing project looking at other single gene disorders such as Becker's and Duchenne muscular dystrophy. Rapid, it includes parallel evaluation of the cost effectiveness, patient acceptability, ethical, legal, and social aspects of NIPT. Rapid, this is an ongoing trial. For NIPT to be feasible, sufficient cell-free fetal DNA must be present in the total cell-free DNA population analyzed. For aneuploidy, the detection rate is 4%. Shortcut sequence analysis, it allows analysis of sequence longer than 1,000 base pairs, and it was therefore one of the first technologies to enable whole genome sequencing. MPS, this is a form of high throughput or NGS that can decode the sequence of millions of the short DNA molecules, like up to 100 of base pairs at the same time. And it is used in PNDT test failure rates, and the failure rates are approximately 3%. So these are known to increase with rising maternal BMI and presence of maternal chromosomal abnormalities and placental mosaicism, as well as in pregnancies complicated by single twin demise. MPS, it has been shown to be able to detect 99% of fetuses with Down syndrome for a false positive rate of less than 1%. And detection of 13 and the 18, it was less successful at 92%. MPS for the NIPT of chromosome 13, 18, 21, and monosomy X for a period of 6 months in 2012 confirmed low false positive rate, which is just 0.2%, and false negative rate 0.5%. Fetal MRI, it can provide an important adjunct in imaging, as MRI can offer superior soft tissue contrast resolution for a range of structural abnormalities. Like in cases of diaphragmatic hernia, where identification of the fetal liver in the thorax, it is useful to enable detailed counseling regarding prognosis and oligohydramnios. MRI, it can assist in the prenatal diagnosis of placenta previa. Most commonly, fetal MRI is used to assist with diagnosing CNS anomalies, and the Health Technology Assessment Program, it funds MRI to enhance the detection. Then MRI US in fusion imaging, it has the advantage that real-time and the Doppler capability of the ultrasound, they can complement high contrasted MRI images to allow improved prenatal diagnosis. Particularly, if we are looking for vascular abnormalities such as veins of the Galen aneurysm, as well as lesions traditionally poorly visualized by ultrasound, including lung masses and cerebral lesions in tuberous sclerosis. Visualizing the vasculature of the monochorionic twin placenta in the treatment of the twin-to-twin transfusion syndrome, then in fetal therapy, including laser treatment for twin-to-twin transfusion syndrome, in utero transfusion for fetal anemia, and prenatal surgery for myelomeningocele and the congenital diaphragmatic hernia. So all of these new techniques, they can be used effectively.